Hello and welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today, we count with the collaboration of the Dr. Maria Lopez Benito and the Dr. Armando Perez de Prado, interventional cardiologists of the Hospital de León. Together, we will review everything you need to know about the hybrid approach of the coronary chronic total occlusions. Join us! This on the screen is a coronary chronic total occlusion, one of the most complex scenarios of the interventional cardiology. Thereby, a chronic occlusion can be defined as a complete interruption of the antegrade coronary flow due to an atheroma plaque that occupies the totality of the vascular lumen during 3 months of evolution at least. The chronic occlusions can cause symptoms such as angina or heart failure. However, it can often evolve silently, being finally diagnosed casually by the performing of a cardiac catheterization. Thus, some authors still openly manifest their doubts regarding the benefit of the different therapeutic strategies available nowadays. However, everybody seems to agree with coronary revascularization when we are treating patients with chronic occlusions that present myocardial viability, symptoms, and ventricular dysfunction. Thereby, and as you can also imagine by the title of our video, today we will focus only in the percutaneous treatment of them. Let's begin! It all begins with a high-quality coronary angiography, because we should be able to identify some technical characteristics of the occlusion, which are the proximal cap. It must be confirmed if there is or there is not a proximal cap, and, moreover, its characteristics described as well, because a tapered cap eases the antegrade crossing of the guide wire, while a blunt or absent cap decreases the chances of success. The occlusion length. The longer the occlusion, the more complex the procedure will result. The distal cap. It is the most proximal or closest point to the recanalization, the location where the occlusion ends and the distal bed begins. In this case, we must define the caliber and the development of the vessel, as well as to discard the existence of bifurcation branches or significant coronary lesions. Collateral circulation. As you know, there is a network of interarterial connections that supply a vascular territory whose proximal blood vessel is occluded. In this case, it is important to describe not only the origin of the network, but also the caliber of the vessels and their nature. Thereby, the development of collateral circulation does not involve myocardial viability, but eases the percutaneous coronary interventionism. Well, let's move on now to the coronary interventionism. There are nowadays two therapeutic paradigms. On one hand, there is the Japanese school, famous for the development of retrograde techniques and the perfectioning of the antegrade ones, building on the selection of patients according to the predictors of success that conform the JCTO score, and optimizing the procedure with the use of intravascular ultrasound, also known as IVUS. On the other hand, we have the American school that has achieved great results thanks to the development of new techniques and antegrade reentry devices, which have ended up being incorporated, along retrograde techniques, into a very helpful therapeutic algorithm known as hybrid approach. In this way, and with a purely academic objective, we will use the hybrid approach to explain the different percutaneous techniques classically described for the treatment of coronary chronic total occlusions. First, we must know that the simultaneous injection of contrast material bilaterally is essential in these procedures, because it will allow us to see not only the proximal segment of the vessel, but also, with the help of collateral circulation, the coronary bed distal to the occlusion. Next, we must choose how to rechannel, antegradely or retrogradely. In order to do so, it is appropriate to characterize the occlusion. So, when we have a tapered proximal cap, collateral blood vessels are not favorable, and the reentry zone has a good caliber, the algorithm suggests us an antegrade approach. Otherwise, the best option is to choose the retrograde approach. Well, let's begin with the antegrade approach. Here, we dispose of two different strategies, one based in the antegrade wire escalation, and the other is based on dissection and reentry methods. But how do we know what to choose? Very simple. The election is based on the length of the lesion, because in short lesions, those less than 20 millimeters, we prefer wire escalation, while in long lesions, the dissection and reentry methods are preferred. And what is the wire escalation? Simple too. It is a strategy that tries to rechannel the occluded artery, taking advantage of the operator dexterity and the properties of the different angioplasty guide wires and dedicated microcatheters. This way, the operator can use three different movements, which are the slide-in technique. This technique uses polymer-coated or hydrophilic angioplasty guide wires that can have taper tips with a tip load around 0.9 and 2 grams. Some examples of these guide wires can be the Scion, Gaia First, Fielder XTA, Fighter, and Pilot 50 guide wires. These guide wires must be gently used without forcing, trying to take advantage of the extremely short curve of the tip to pass through the soft chronic occlusions or with microchannels. The drilling technique. This technique uses high support angioplastic guide wires with elevated tip loads around 3 and 12 grams. Some examples can be the Progress, Miracle, Ultimate, Gaia Second, and Scion Black guide wires. These guide wires must be handled combining longitudinal movements with fast and controlled rotational movements that cover the 360 degrees. This technique is helpful in cases of long or hard occlusions, loaded with plenty collagen and calcium. And that is why it is necessary to use not only microcatheters, but also high support catheters, body wires, or sometimes guide extension catheters. And finally, the penetrating technique. With this technique, rigid guide wires with elevated tip loads are used. An example can be the Progress, Confianza, Gaia Third, or Miracle guide wires. Short and vigorous longitudinal movements are performed, alternating with discrete rotational movements of less than 90 degrees. This technique can be helpful when traversing the proximal capsule of the occlusion is desired. That is why the microcatheter needs to be very close to the tip of the guide wire. After the initial perforation of the capsule, these guide wires tend to be replaced by others less aggressive, with the intention of avoiding complications such as, for example, the perforation of the adventitia. In this way, it is easy to understand the involuntary and recurrent incursion of the guide wire in the subintimal space is a frequent event. For these motives, the operator can use, if he or she needs to, a set of specific techniques with the intention of piercing the occlusion by its true light. These are the parallel wire technique. It consists in leaving the wandering guide wire inside the subintimal space, remove the microcatheter, and use this device to advance a second guide wire, one that has a different curve and greater penetration power. In this way, we avoid that the second guide wire advances by the same way, preventing the subintimal dissection from progressing uncontrollably and from compromising the luminal crossing of the occlusion, while we change the configuration of the stump and acquire support to cross with the second guide wire. In these cases, the use of dedicated microcatheters with two lights can ease the procedure. The Seesaw wiring technique. This is a variation of the previous technique, but as a difference, the microcatheter is not changed. Rather, the first one is abandoned along with its guide wire, and a second microcatheter is introduced with a second guide wire. On its own, sometimes the problem is not the subintimal incursion of the guide wire, but the inability to access the occlusion or to advance luminally through it. In the first case, the open sesame technique can be used. It consists in advancing a high support guide wire to a near lateral branch and posteriorly inflate an adequate size balloon with the objective of changing the spatial configuration of the proximal cap and better expose the access zone to the occlusion. In the second case, when we lack support to advance the guide wire through the occlusion, we can re-anchor a balloon in it or in a lateral branch with the intention of achieving a supporting point. This is called the anchor balloon technique. Finally, we have the distal side branch technique, useful in those cases where the guide wire is unable to cross through the occlusion because there is a bifurcation branch in it. In this case, we take advantage of the tendency of the guide wire to head to the lateral branch and we inflate a balloon in it with the intention of changing the spatial configuration of the occlusion and to ease now the crossing of the guide wire. So, what happens if the wire escalation fails or if the lesion is too long? In such cases, we use the dissection and reentry techniques. These techniques use the subintimal space as a bridge to the occlusion, for later re-entering distally into the vascular lumen. Some of these techniques are the subintimal tracking antegrade reentry, or STAR, which consists of voluntarily opening an entrance door to the subintimal space with a high support guide wire and posteriorly replace this one for a hydrophilic knuckle wire that is handled with spiral movements that increase the plane of dissection until reaching an optimal distal zone that allows the luminal reentry of the guide wire. The problem is that the subintimal dissection can be difficult to control, which can jeopardize the flow of the lateral branches and the distal reentry. This is why this technique has suffered some modifications throughout the last years, with the objective of minimizing the negative impact of the knuckle wire. One of these modifications is called contrast-guided STAR, and it consists in replacing the knuckle wire by subintimal injections of contrast made with a microcatheter, which allows to simultaneously generate and visualize a plane of dissection and ease the reentry with it. Another modification is the limited antegrade subintimal tracking, or LAST, that generates a discrete subintimal dissection and an early reentry by preformed polymeric guide wires bent on the tip, which, sometimes, can be supported on a Venter microcatheter. Last but not least, we have the nowadays most popular antegrade dissection and reentry technique, the bridge point. With this name, we know a set of devices designed to work coordinately with the objective of antegradely rechanneling chronic occlusions. These are the microcatheter crossbars, the flat balloon Stingray, and the reentry guide wire Stingray. It all begins with the introduction of the coaxial microcatheter crossbars, an over-the-wire device, until it reaches the proximal cap. Here, the angioplasty guide wire is removed and the catheter is advanced with fast bidirectional rotational movements so that the rounded and atraumatic tip of the device is able to advance luminally through the occlusion in up to 40% of cases, or is able to create a small and controlled subintimal dissection tract in the rest of the occasions. Once the crossbars has reached the subintimal space, the angioplasty guide wire is introduced again and the microcatheter crossbars is exchanged for the flat balloon Stingray. The inflated balloon has a wide extension and a reduced thickness, allowing it to securely hug the vascular lumen from the subintimal space. This balloon possesses three ports. One is the distal port, which is the port used by the guide wire over which this balloon coaxially navigates, while the other two ports are lateral and are located in opposite sides of the device. One looks at the adventitia and the other looks at the intima. After choosing the adequate angiographic projection, the Stingray guide wire is advanced through the intimal port and the intima is perforated with the objective of accessing again the vascular lumen. Right after, the flat balloon is advanced and the microcatheter is moved to the re-entry zone in order to replace the Stingray guide wire with a less traumatic and, therefore, safer working guide wire. Wonderful! Solve the problem of the antegrade progress of the guide wire, the rest of the angioplasty would continue as usual. This means preparing the lesion and implanting as many drug-eluting stents as necessary. However, what happens if we are not capable of antegradely reaching the distal bed of the vessel? Well, it means that we can use the right side of the algorithm, that is, the retrograde approach techniques. The retrograde approach techniques take advantage of the vessels of the collateral circulation as bridges to access the distal bed of the occlusion with the guide wire. Thereby, using different techniques of interventionism, coronary recanalization can be tried from the distal portion of the vessel. So, the ideal collateral blood vessels are usually the septal branches, because they tend to be vessels with a straight and short path, with a compliant wall, and without contact with the pericardial space. All of this increases the probabilities of success and simultaneously decreases the risk of complications such as, for example, cardiac tamponade. Let's take a look then at the retrograde techniques. Independently of the retrograde technique used, all of them have a first common step, accessing the distal bed of the occluded vessel through the collateral branches that offer the donor blood vessel. Thus, it is recommended to use hydrophilic or polymer jacket coating guide wires to achieve this. However, Even if these guide wires are great, they will not be able to meet their goal if they do not count with the help of a microcatheter. In this particular case, the microcatheter is an essential tool for the success of the procedure because it does not only offer support, push, or the opportunity to exchange guide wires, but also offers the opportunity for dilating the collateral vessel with the intention of facilitating the displacement of balloons that could be posteriorly necessary during angioplasty. Let's now cross the occlusion. First, we need to, just like in antegrade approaches, determine the length of the lesion. If the lesion is short, it is recommended to use the retrograde wire crossing and retrograde wire escalation techniques, changing the automatic guide wire we had previously used in the collateral vessel for a guide wire with greater penetration power, like, for example, some of the Gaia family. The objective is to luminally cross the occlusion from distal to proximal and posteriorly advance the guide wire until it gets into the antegrade catheter, where trapping occurs. That is, we trap the guide wire with a balloon with the purpose of generating enough support so that the retrograde microcatheter advances. Sometimes it is not possible for the guide wire to get into the catheter, and it is necessary to hunt the guide wire with a lasso in the aorta. In any case, after concluding the circuit with a microcatheter, the guide wire is exchanged for another much longer, or the retrograde catheters are cut out with the purpose of, in both cases, externalizing the guide wire so that the angioplasty can continue antegradely. In case the occlusion is very long or the luminal cross is unsuccessful, some mixed techniques can be used. That is, techniques that use two guide wires simultaneously, one antegrade and another retrograde. The kissing technique is the simplest of these techniques because it only consists in leaving the retrograde guide wire inside the occlusion so that it modifies the geometry, works as a marker, and creates a canal over which an antegrade guide wire can be advanced so it can reach the distal cap. The problem is that the guide wires sometimes cannot find each other on the same plane. For this reason, a lot of authors recommend using directly the retrograde dissection and re-entry techniques. In this way, we have, for example, the controlled antegrade and retrograde subintimal tracking technique, aka CART, which consists in advancing both guide wires to the subintimal space. Right after, a balloon is advanced through the retrograde guide wire and is inflated in the subintimal space, increasing the dissection zone in a controlled way. Posteriorly, the balloon is deflated but not removed because this one must prevent the collapse of the subintimal space and act simultaneously as a bullseye for the advance of the antegrade guide wire. When this last one reaches the distal cap, the angioplasty continues as if it had begun as an antegrade approach. Then there is the cart reverse, which bases on the previously described technique, with the difference that in this case the balloon that will be used to dissect the subintimal space is introduced over the antegrade guide wire, reasons for which the retrograde guide wire must advance to the balloon and re-enter the artery proximally. Once there, the rest of the angioplasty continues as if it had begun as a retrograde wire escalation. Finally, we have the knuckle wire technique, which, as you can imagine, uses a knuckle wire retrogradely to create an area not controlled for subintimal dissection, which will posteriorly be exploited by an antegrade guide wire to distally advance until it achieves the luminal reentry. In summary, the treatment of chronic occlusions is one of the most complex challenges of the coronary interventionism. For these reasons, it is convenient to dispose not only of the appropriate instruments, but the necessary experience in order to be able to use them properly according to the different available techniques and the features of each case. In this way, we say goodbye. It has been all for today in Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!